Hello everyone, very good evening and good morning to Dr. Krish Patel as well. From AstraZeneca, I'm Dr. Prashanth, the Regional Medical Advisor. I would like to extend a very warm welcome to all of you for this webinar on the expert opinion on management of high-risk CLL with Acalabrutinib. It is my honor and pleasure to welcome the chairperson for today's webinar, Dr. SVSS Prasad, who is a senior medical oncologist with over 30 years of experience from Apollo Hospitals in Hyderabad. He is also credited as the first Indian to be qualified in both pediatrics and oncology, and his interests are in the field of pediatric malignancies, hematological malignancies, and bone marrow transplantation. I would now like to welcome the chairperson, Dr. Prasad, to deliver the welcome note and take this meeting forward. Welcome to you, sir.
Thank you, Prasad. My greetings to everyone. And I would like to introduce Dr. Krish Patel after a few words on the recent today's discussion topic. We all know that CLL treatments have evolved over the last few years, especially people of our generation were only having the bendamustine regimen, and earlier to that the FCR regimen, and chemotherapy was the mainstay for the deserving cases. The earlier cases were mostly on the observation mode. But now with the arrival of ibrutinib and other drugs, the classification into the higher risk, intermediate risk and low risk has happened, and then we are trying to apply these drugs, especially in the high risk CLL in an appropriate fashion. And the scenario has changed as to how we manage these patients, and better outcomes, better progression-free survivals and overall survivals. And the latest child on the treatment is Acalabrutinib, so to say. And we would have an expert opinion from Dr. Krish Patel on the management of high-risk CLL with Acalabrutinib, and followed by some panel discussion by Dr. Pawan Kumar, consultant medical oncologist from the International Hospital, and a beautiful panel of members sitting on his panel meeting. And with this small overview of today's program, I would like to introduce Dr. Krish Patel. May I have the slide about Dr. Krish Patel? Yeah, he is Director of Lymphoma Program at the Swedish Cancer Institute, Seattle, Washington. And he would be talking on high-risk CLL with Acalabrutinib. What is high-risk CLL and everything? I'm sure Dr. Krish Patel would be talking about it in this lecture. Dr. Krish Patel, please.
Sir, you need to unmute yourself, sir.
Thank you very much. Certainly to be my pleasure to be with you all today, and thank you for having me. So I'm going to give a discussion about high-risk CLL.
Hello, Dr. Krish.
Yes.
So just change the presenter review, sir.
Can you see it now?
Still not, sir.
Can you see it now?
Yeah, we can see the slide, but it is in the presenter review, sir.
Okay, and how about now? Can you see my slides now? Or let me try this again.
So just you can click.
I think it's fine now.
Sir,
just
we can see
Are you
your
able to
slide.
see my slides?
Sir,
Yes.
we can see your slide, but right side your like logo is cutting from Swedish Institute. So
that seems to be maybe a Zoom issue. So you can't see the bottom corner, is that what you're saying in the slides?
Yes, bottom corner, that Swedish, it is written. So you can do it, enable editing over there.
Okay, let me try this. I apologize. Let me try one more time here. How about now? Do you have the full view now?
Yes, sir, perfect. Yeah, you can. Yeah.
Perfect. Well, thank you all. It's my pleasure to be with you. I'm Krish Patel from the Swedish Cancer Institute in Seattle, Washington in the US. Today, I'm going to be talking to you about management of high-risk CLL with a focus on acalabrutinib. But to give you an overview of what we'll cover today, I just thought we'd start with some discussion around how we approach CLL currently in the US, some of the emerging evidence from real-world studies, and then review some of the data that informs use of acalabrutinib in CLL. And then we'll finish with a few examples of real-world evidence of use of acalabrutinib, including some case discussions. So you all are well familiar with this, but as we think about treatment for CLL, it's important to recognize there is a heterogeneity in this disease, and we have patients who are certainly at risk for poor outcomes. What we typically would consider high-risk patients are those with IGHV unmutated status, TP53 abnormalities either by FISH or mutations in the gene itself, deletion of 11q or complex karyotype. And these patients in particular have been treated in different treatment paradigms from chemoimmunotherapy for some years now. And you see here in the US, we have several different approved options for treating such patients. These can include strategies using a BTK inhibitor. The two approved in the US are acalabrutinib as a monotherapy or in combination with the anti-CD20 antibody obinutuzumab, or ibrutinib in combination with either rituximab or obinutuzumab or as a monotherapy. We also have another targeted therapy, the BCL2 inhibitor venetoclax, which can be combined with obinutuzumab in fixed duration therapy. And currently in the US, there are a number of ongoing triplet and doublet clinical trials, so combinations of BTK inhibitors with BCL2 inhibitors, plus or minus an antibody. For patients who have standard or lower risk CLL, these might be patients who are IGHV mutated, they are TP53 intact, and there still may be a role for chemoimmunotherapy for select patients. Certainly in the US, this is really restricted to patients with IGHV mutated status. For young and fit patients, that might include FCR-based chemotherapy, recognizing that long-term disease-free relapse is a possibility for around 30% of patients, albeit CLL is a disease primarily of older adults, so it can be challenging to deliver FCR in CLL. Other chemoimmunotherapies listed here, and then we see the same options for treatment that we can use in high-risk treatment. So our targeted agents, BTK inhibitors, BCL2 inhibitors, work equally well in both high-risk and standard risk patient populations. And so this is, I think, very familiar to all. In general, I'd say in the US, there has been a shift away from chemoimmunotherapy in all patients for a variety of reasons. And we'll talk a little bit about that. So these data come from a real-world registry study performed by a number of US CLL centers called the Inform CLL Registry. The registry enrolls patients or includes patients that were enrolled between 2015 and 2018. And in essence, what we're looking at is patterns of care delivery. So in previously untreated CLL, which is a little more than half of the population in the registry, what we see is that over time, there is less and less chemoimmunotherapy, about 40% of the patients in the registry treated with chemoimmunotherapy, and an increasing focus on novel agent therapy. In the relapse refractory setting, this is perhaps even more, I think, pronounced, and makes sense given that our initial approvals of some of these novel agents, including BTK inhibitors, including BCL2 inhibitors, really occurred first in the relapse refractory setting. I'd look at this time frame and say, you know, these data are now old, and there's been a number of important trials that have published data beyond 2018 that have changed our practice patterns, in particular the approvals of venetoclax and obinutuzumab based on the CLL14 study, and then more recently acalabrutinib based on the Elevate treatment naive study, and then in the relapse refractory setting based on the Ascend study. So these data simply show that as time goes on, there's less and less chemotherapy use in treatment of CLL in the US. What about some of the unmet needs in CLL? So we recognize that ibrutinib has been really a paradigm shifting therapy, but there are still a lot of considerations that we think about and ways to improve upon the care of patients with CLL based on our experiences with ibrutinib. For example, long-term data, both from clinical trials of ibrutinib as well as real-world evidence, suggests that discontinuation of therapy due to adverse events can be an issue. This has been the focus of study in several different real-world evidence analyses, and also in a pooled analyses published by Jan Berger. And here what we note is across clinical trials of ibrutinib in the first-line setting in CLL, we see that more than half of patients require dose interruptions, about 15% of patients in these trials require dose reductions, and about 10% actually had to discontinue the drug due to an adverse event. And those adverse events can be varied, but include pneumonia, hemorrhage, and atrial fibrillation. So while ibrutinib has really been a paradigm shifting therapy, again, we have a lot of room for improvement. Building on this is real world evidence taken largely from US and European centers. So these data come from patients treated with ibrutinib outside of a clinical trial. And what we see is similar types of discontinuations and dose reductions. So this is a retrospective study done by Jeff Sharman. And what we see is in a study of over 400 patients, about 50% of patients in the study treated with frontline CLL with ibrutinib needed to discontinue the therapy. Perhaps not surprisingly, a proportion of those patients for disease progression or death, but about a quarter of the patients, or 23% of the patients, had to discontinue the ibrutinib because of an adverse event. And actually, in these real-world evidence studies, the adverse events that lead to discontinuation may be different than those in trials, including symptoms or adverse events that relate to quality of life, like arthralgias. In this study, the median duration of ibrutinib treatment was just 15.2 months. And so that tells us that while patients in clinical trials certainly represent one group of patients, patients outside of those trials may have other considerations that lead to discontinuation. So discontinuation of ibrutinib is a problem in frontline CLL. Well, why might that be? What are some of these adverse events that could be driving this discontinuation? If we think about adverse events from clinical trials of ibrutinib, what we see is that certainly atrial fibrillation is an adverse event that happens in a reasonable number of patients. Somewhere between 11 to 16% of patients in clinical trials of ibrutinib have developed atrial fibrillation that is new or worsening in onset at 3 years. In real-world evidence studies that have been done, that number perhaps is higher still. 12 to 25% of discontinuations may be due to AFib. Bleeding can be a challenge. So in clinical trials, grade 3 bleeding, this is the kind of bleeding that leads to hospitalization or some kind of intervention, may occur in about 8% of patients. And in real-world evidence data, this also is a reason for discontinuation in these data sets. And so the cumulative incidence of things like hemorrhage, atrial fibrillation, and then hypertension, which is a time-dependent adverse event and actually increases with time on ibrutinib, can be challenging for some patients and lead to discontinuations. And just to put more focus on these adverse events, these are of course important. We know that blood pressure leads to cardiovascular outcomes, and so patients who have new or worsening hypertension on ibrutinib may be at risk for cardiovascular outcomes. And we can see that in an analysis done by the Ohio State Group, which looked at major adverse cardiovascular events in patients treated with ibrutinib. And what we see is that in patients who had new or worsening hypertension, as you see here on the right, there was a time-dependent increase in major adverse cardiac events, really without a plateau in those patients who had developed new or worsening hypertension. And so if we think about the balance of toxicity to control of disease, while we certainly get very good control of disease with ibrutinib, there is room for improvement in terms of long-term side effects and what that means for the overall health of our patients. In that same analysis, if we look at hypertension as a function of other predictive factors, so simply saying, was this increase in hypertension related to expected kind of increase in incidence of hypertension with age and other factors, what we see is that in the patients in this analysis who were on ibrutinib, they had a much greater cumulative incidence of new hypertension than an age-matched control patient who was not on ibrutinib. And so really these again suggest that this is an important toxicity of ibrutinib. And again, this is time dependent. We typically don't see this until some months after the patient has been on this therapy, and this can continue on for some time. So what about other BTK inhibitors? So I mentioned that, ibrutinib as a paradigm-changing therapy has been so important because it has helped shift us away from chemoimmunotherapies, especially in high-risk patients. But if we have adverse events that we'd like to avoid, how do we potentially do so? And this is where I'll talk about acalabrutinib, which is a next-generation BTK inhibitor, which has in vitro more selectivity for BTK and less off-target kinase inhibition. So this is a kinome scan map. This is an in vitro assay. And what this shows us is the red circles show us kinase inhibition. The larger circles demonstrate more potent inhibition. And what we can see is that ibrutinib inhibits a number of different kinases within the TEC family. That's here in this upper left purple quadrant. And then what we see is a number of different outside of the BTK family kinase inhibition as well. Acalabrutinib, in contrast, in vitro assays, has much more selective kinase inhibition centered primarily around BTK. You can see that in the table on the right, with far less off-target inhibition in vitro, including less TEC inhibition and less EGFR inhibition. Now, these off-target kinases may be clinically relevant in some of the adverse events that we've discussed. So we know that TEC is expressed in cardiac tissues as well as in platelets. And so inhibition of TEC is thought to be potentially one mechanism towards bleeding and cardiac toxicity. So less inhibition of TEC may be beneficial in that regard. And EGFR, as you all know well, when inhibited, leads to a number of different adverse events for patients, including things like rash, diarrhea, and potentially arthralgias. So having a more selective kinase inhibitor may allow us to better to have a differentiated safety profile. And this is what we'll talk about in the clinical trials that have studied acalabrutinib in CLL. So the first study that I'll talk about is the Elevate Treatment Naive study. This study was presented first at ASH in 2019 by Jeff Sharman. This was a study of patients with previously untreated CLL. Patients had to meet the IWCLL criteria for therapy. And importantly, patients in the study could be enrolled if they were on a anticoagulant other than warfarin, but no patients with warfarin were enrolled in the study. There were 3 arms in the study. The first arm was the control arm, obinutuzumab and chlorambucil given in the standard fashion. The second arm is an arm of obinutuzumab plus acalabrutinib, with acalabrutinib being given as 100 milligrams twice daily, and then a monotherapy acalabrutinib arm. The study was powered to look at the primary endpoint of progression-free survival, specifically with the comparator of each of the acalabrutinib arms being the obinutuzumab and chlorambucil. These were the data that the efficacy data presented at ASH in 2019. And what you can see is at 24 months, progression-free survival was superior in the acalabrutinib containing arms. The blue line here represents the acalabrutinib and obinutuzumab arm. The purple line here, acalabrutinib monotherapy. And you see the hazard ratio for each of those treatment arms compared to the chlorambucil and obinutuzumab. So clearly a superior progression-free survival for acalabrutinib containing arms compared to the comparator of chlorambucil and obinutuzumab. If we look across different subgroups, and of course, the study wasn't powered to look at subgroup differences, so this is really exploratory, what we see is that the benefit tends to be in the favor of acalabrutinib across different subgroups, including patients with high-risk disease. So patients with P53 aberration, patients with deletion 11q, patients with unmutated IGHV and complex karyotype. What about adverse events? So if we look at the adverse events that were reported in the study, what we note is the most common adverse event associated with acalabrutinib was headache. This is typically grade 1 and grade 2, very few grade 3 headaches, and these are typically transient and can be managed with things like acetaminophen or caffeine. Importantly, in my own experience, these headaches tend to be very early in the therapy and tend to improve with time and rarely, if ever, lead to discontinuation of the therapy. If we look at other adverse events, we can see some diarrhea, albeit a relatively low grade, grade 1 and 2. Neutropenia can occur. That seems to be higher with the combination of obinutuzumab, perhaps not a surprise given that that agent itself can cause neutropenia. And then what we see here is overall a low proportion of grade 3 or 4 toxicities in the acalabrutinib treated patients. If we focus on, in particular on adverse events of clinical interest, so for example, adverse events that might be more common or potentially more common in BTK treated patients, what we see is a low overall incidence of atrial fibrillation. So in the acalabrutinib treated patients, atrial fibrillation occurred in less than 4% of patients. There was very low grade 3 or 4 atrial fibrillation. We see here one case between the two arms. There were no ventricular arrhythmias reported. Hypertension, also importantly, at a relatively low incidence with few grade 3 or greater hypertension. And then importantly, bleeding. We can see still bleeding, and this may include contusion as well, mostly grade 1, grade 2, but importantly, grade 3 and 4, the type of serious bleeding that might lead to hospitalizations or potentially even discontinuations of medications was low in the acalabrutinib treated patients. We do want to be aware of infection risk. So we know that this is something that patients both with CLL and CLL going under therapy, we need to be aware of this, and this is important and noted in both treatment arms here. The other thing I'll just point out is when we're looking at these adverse events, these are cumulative incidences, so and reflect the time on treatment. So the time of follow-up for these adverse events for chlorambucil and obinutuzumab is just 7 months. That was the prescribed therapy, whereas for the two acalabrutinib treated arms, this is a therapy given continuously, so there's a much longer time period for reporting of these events. These data have recently been updated at ASCO with a median follow-up of 46.9 months. And what we see here is a continued superiority of the acalabrutinib treated patients compared to the chlorambucil and obinutuzumab. So at a progression-free survival of 4 years, 87% for the combination of acalabrutinib and obin, 78% for the patients with acalabrutinib monotherapy compared to just 25% for the chlorambucil obinutuzumab treated patients. This is also true for the patients with p53 aberration. And so we see here patients with deletion 17p and or mutated TP53. And what we see is that for these high-risk patients, they seem to be doing quite well with the median progression-free survival not yet reached in the acalabrutinib treated arms. And at 4 years, just about 3/4 of patients free of disease progression or death. And then here, if we look at overall response rates, this also comes from the 4-year follow-up. What we see is that the overall response rate to all of the treatment arms is high, but in particular, we see, I think slightly more complete responses numerically in the combination arm compared to other arms in the study. And the estimated 48-month overall survival appears to be highest in that combination arm as well. And again, we need continued follow-up of the overall survival analysis, but these are encouraging data. At that 4-year follow-up, if we look again at adverse events, are we seeing any new signals? And importantly, I think the answer is no. We still see a low rate of atrial fibrillation, low rate of grade 3 or 4 atrial fibrillation. In terms of major bleeding, again, that remains low here at less than 3% in the acalabrutinib treated patients. And I think even more importantly, hypertension, which as I mentioned, can be a time-dependent adverse event. We see, again, low rates of grade 3 and 4 hypertension and hypertension less than 8% in both the acalabrutinib treated arms. This is just another way of looking at the adverse events, looking at them by time. So the purple color represents an adverse event with onset in the first year, green in 1 to 2, blue in 2 to 3, darker blue in 3 to 4, and this yellow color in more than 4. And what we see is that overall, most adverse events in the acalabrutinib treated arms occur predominantly in the first year, with lessening of the incidence of adverse events or new adverse events as time goes on. The most common, again, adverse events seen in acalabrutinib treated patients were headache, diarrhea, fatigue, arthralgia, cough. So in summary now, with longer follow-up, now 46.9 months, the median progression-free survival continues to be longer for acalabrutinib-treated patients than chlorambucil obinutuzumab treated patients. And this is consistent across high-risk subgroups. Really, I think at 48 months, when we look at this progression-free survival, we see, the high majority of patients continue without disease progression or death. Overall response rates are higher in the acalabrutinib treated arms, with potentially a higher complete response rate with the combination of acalabrutinib and obinutuzumab. And then we can see, again, in terms of cardiovascular adverse events and adverse events of special interest, that these remain low and consistent with the findings from the interim analysis. And then certainly important to note, when we add the antibody to acalabrutinib, we do see an increase in grade 3 or 4 infections. And so this is, I think, an important consideration to individualize to our patients. So now I'll move to the relapse refractory setting. So these are the data from the ASCEND clinical trial. These were initially reported at EHA in 2019. So this is a study of patients with relapsed and refractory CLL. Stratification was based on the presence of deletion 17p, yes or no, performance status, and number of lines of prior therapy. And the primary endpoint for this study was progression-free survival. The 2 treatment arms were acalabrutinib monotherapy, 100 milligrams oral twice a day, compared to investigators' choice between either idelalisib plus rituximab, the PI3 kinase inhibitor, or bendamustine and rituximab. And I think this study is really important because this is the first study that really randomized a BTK inhibitor to another targeted therapy, idelalisib. And so these data certainly are important in that respect. So these are the independent review committee progression-free survival analysis that was reported in 2019. And what we see here is the purple line, which represents the acalabrutinib treated patients with a superior 1-year progression-free survival compared to either of the 2 regimens in the investigator choice arm. Importantly, there didn't seem to be any major difference between the idelalisib and the bendamustine treated patients, albeit the number of patients treated with bendamustine rituximab was smaller than the number of patients treated with idela, but you look at the hazard ratios compared to acalabrutinib and they look quite similar here. And if we look at the same analysis in patients with high-risk cytogenetic features, so these are patients with p53 aberration or unmutated IGHV or deletion of 11q, we see the same kind of separation of the curves with the 1-year PFS again of 88% in the acalabrutinib treated patients compared to 66% in the investigator's choice arm. Adverse events in the ASCEND trial look, I think, for acalabrutinib similar to what we saw in ELEVATE treatment naive. So headache was the most common adverse event, neutropenia, also something we need to watch for, diarrhea, and other cytopenias like anemia and other adverse events listed here. I think in contrast to the investigator's choice arm, this is important. We recognize with either chemoimmunotherapy or with idelalisib, we can have a substantially higher neutropenia rate, and that was noted in this study as well. Looking again at adverse events that may be of special interest when using a BTK inhibitor, atrial fibrillation of any grade was low at 5% with low grade 3 or greater AFib. And again, hypertension also low at 3% and 2% of grade 3 or 4 variety. Bleeding, we can see patients develop bruising and contusions, but again, a low risk of severe bleeding or bleeding that requires hospitalization. So in summary, these two trials are very important, and they tell us a lot about the efficacy and toxicity of acalabrutinib in CLL. So the Elevate treatment naive study demonstrates superior efficacy of an acalabrutinib regimen either as a monotherapy or in combination with obinutuzumab compared to chlorambucil and obinutuzumab. In the Ascend study, we see superior efficacy compared to either idelalisib, rituximab, or bendamustine rituximab. And in aggregate, these studies demonstrate a consistent and differentiated safety profile, which is one that includes low rates of AFib, of severe bleeding, as well as quality of life adverse events like arthralgias. And now I'll just shift our focus to some of the real world evidence for use of acalabrutinib. Of course, acalabrutinib has been approved for CLL more recently, so the number of patients that have been treated outside of a trial may be smaller, but we can start to get some insights from those patients as well, much like we have in real-world evidence studies of ibrutinib. So this was a study done by Maryam Yazdi that was published and presented at ASH in 2019. This was 69 patients across the US, 9 different US centers, treated with acalabrutinib. Most of these patients were treated in the relapse refractory setting. 78% importantly had been on a prior BTK inhibitor and mostly had been switched due to intolerance. And what we see in this study is that, overall, the majority of patients who were being treated with acalabrutinib were being treated because of intolerance to ibrutinib. So that was 68% of the patients in the study. Very few of the patients had disease progression on the immediate prior line of therapy. But overall, what we saw is that the types of adverse events noted here were consistent with the trials. So low rates of diarrhea, low rates of bleeding, low rates of atrial fibrillation. And in this study of patients in the relapse refractory setting, about 19% of patients discontinued, with about 12% due to AEs. And so what we see is that the discontinuation rate is similar to trials of acalabrutinib in ibrutinib intolerant patients. So what I mean by that is this acalabrutinib has been studied in the ACCL-001 study in patients who might be intolerant to ibrutinib. And we see, generally speaking, that patients can switch from one agent to the other if intolerant and have a low risk of discontinuation. What about hypertension and atrial fibrillation? So these data come from a pooled safety analysis presented by Rick Furman at ASCO. So this is a pooled safety analysis of patients treated with acalabrutinib monotherapy across multiple different clinical trials. And so this is over 1,000 patients. And what we see, again, is that hypertension has a low incidence here, 8%, and that there seems to be some plateau of that effect, which is, I think, important. We don't continue to see a rise in this curve over time. Atrial fibrillation, similarly so, in over 1,000 patients treated, any grade AFib of 4%, grade 3 or greater, less than 1%. So again, these are really, I think, encouraging safety data when we think about the duration and the number of patients in this pooled safety analysis. So how do we think about these data, or how do I think about these data? I'll share with you my own practical personal experiences thinking about ibrutinib versus acalabrutinib in CLL. It's not unusual for patients on ibrutinib, maybe up to a quarter of patients, to call the clinic, primarily reporting symptoms that we consider low-grade toxicities, but things that really can affect their quality of life, things like arthralgias, fatigue in particular in the first few months on ibrutinib. In patients who are on other bleeding risk medications, so for example, or anticoagulants or perhaps antiplatelets, this can be a challenge for ibrutinib because of the risk of bleeding. And rarely we can see ventricular arrhythmias. While this is rare, this is certainly a very scary experience if anyone has ever seen this. These are things that we have to consider when we're thinking about use of ibrutinib. In contrast, in my own experience using acalabrutinib, we get very few calls to the clinic with quality of life type adverse events. Headache is something that we can see. This is often very responsive to caffeine and acetaminophen and tends to lessen with time. Bleeding in general seems to be a notch lesser. And generally speaking, there are far fewer dose interruptions or reductions that I've needed to make in patients who are treated with acalabrutinib. This is a medicine we often can start and have, confidence that the patient will be able to continue it at the dose prescribed. Ultimately, and I should update this, we've all seen the Elevate relapse refractory randomized trials now, but these two agents have been compared head to head in the Elevate relapse refractory study. And so those data, as you know, have been presented at summer congresses and are an important reference. But there does seem to be, importantly, a differentiated toxicity profile. So acalabrutinib, based on all of the data we have, is associated with a low risk of atrial fibrillation, low hypertension, and low risk of severe bleeding. So I just thought we'd wrap up by demonstrating a few cases that I think highlight some of these differences. This is a patient of mine that I treated with treatment-naive CLL. This was a 72-year-old female patient who presented with initially symptoms of low-grade fever, abdominal pain, and progressive fatigue over several months. She liked to play golf and had noted her ability to do so was declining due to fatigue. Her relevant medical history included hypertension, dyslipidemia, and some mild stage 2 chronic kidney disease. She was taking blood pressure medicine and atorvastatin for her dyslipidemia. And on her exam, perhaps not surprisingly, she had splenomegaly. She had several lymph nodes that were enlarged. Her hematologic indices are shown on the right. She was anemic. She had a mild leukocytosis, primarily of absolute lymphocytes. She was thrombocytopenic with an elevated beta-2 microglobulin. She had peripheral blood flow cytometry, which demonstrated an immunophenotype consistent with CLL. FISH testing demonstrated that she had deletion of 11q, but no deletion of 17p. And importantly, here in our practice, we do NGS for TP53 mutations on all patients at the time of diagnosis or time of first treatment. And this patient had a nonsense TP53 mutation and was IGHV unmutated. So clearly, in many respects, a high-risk CLL patient. Because of the 11q abnormality and the abdominal pain that she described, we wanted to assess for bulky adenopathy. She had a CT scan, which did in fact demonstrate a substantial bulky adenopathy in the retroperitoneum with conglomerate lymph nodes more than 10 centimeters. And when we thought about treatment options, appreciating what's available to us at the time this patient was treated, either venetoclax-based regimens or alternative BTK inhibitor regimens, this patient, importantly, did not want to be hospitalized with the bulky disease, would have been at high risk for tumor lysis syndrome with venetoclax and obinutuzumab, and did not want to pursue that therapy, and really was very interested in getting back to playing golf. And so quality of life type symptoms were important to this patient. So we chose to treat this patient with acalabrutinib monotherapy, and this patient has been doing very, very well on acalabrutinib alone. A second patient that I think highlights a different problem is that of patients who may be intolerant to ibrutinib. So this is a patient who is a little bit younger, 66 years old, had been on ibrutinib for initial treatment of CLL for about 6 months. This patient had started the ibrutinib before the approval in the US of acalabrutinib, so was on ibrutinib from January 2018, and then presented to our emergency room with severe pain in their leg for about 2 days. When the patient started ibrutinib, they had lymphocytosis, thrombocytopenia, and progressive fatigue. And at the time that they were coming into the emergency room, now 6 months on ibrutinib, largely things like splenomegaly and adenopathy were absent. The patient did have edema in the left thigh. It was asymmetric, and sorry, that up here should also read left. And essentially, this patient had new anemia. So 1 week prior, had a relatively or close to normal hemoglobin. And this patient's disease characteristics are shown here. This is a patient with standard or even favorable, standard risk CLL, but high risk by IGHV unmutated status. And this patient had a CT scan to evaluate that left leg asymmetry and pain and anemia, and perhaps not surprisingly had a new intramuscular hematoma, so it had an intramuscular bleed. This patient unfortunately required a fasciotomy for compartment syndrome. And when the patient came back to see us in clinic after recovery from this acute period, we really had to think about, okay, how will we continue the patient's CLL therapy? The patient had been responding to ibrutinib, but had developed this intramuscular hematoma while on ibrutinib. Really, there were no other clinical factors that would explain why the patient had the bleeding. At the time, and this was in 2018 in the US, we did have approval for venetoclax as a monotherapy in patients with 17p deletions, although this patient did not have a 17p deletion. And acalabrutinib was available despite not being broad in the US for cell lymphoma. And so ultimately, after a discussion with the patient, not wanting to leave the BTK inhibitor class, we did choose to treat this patient with acalabrutinib monotherapy. And fortunately, this patient has done very, very well with this monotherapy, has not had any recurrent bleeding, no other adverse events, and the patient continues to evolve a partial response with lymphocytosis with normalization of other parameters. So a patient who was very, I think, distraught and worried and unhappy had a very good outcome in this case. And then I'll just point out that acalabrutinib is not indicated in patients who are intolerant to ibrutinib, but this is an example of a use of that therapy and I think a point to show a differentiation in adverse events. So this is some of the prescribing information listed here. We've covered much of this, and I'll just note that there are certainly interactions that we want to pay attention to.
Thank you, Dr. Krish Patel. We have a couple of questions if you are willing to take them.
Sure.
Yep. One, Dr. Thomas Ingeria asks if a patient is doing well on ibrutinib but has hypertension issues, would you add hypertensives, antihypertensives, and then treat the patient, continue, or do you want to change?
Yeah, this is a really good question. I think it's a question that comes up commonly as we have more and more information about hypertension and ibrutinib. You know, in my own personal experience, I find sometimes that hypertension is difficult to manage, hypertension due to ibrutinib. And, you know, in general, I would say my practice now has been to consider switching the agent. I used to probably add hypertensive medicines, but then I find sometimes it can take 2 or 3 medicines to control that hypertension. And now I feel more comfortable making that switch to acalabrutinib if the disease is otherwise responding well.
And if atrial fibrillation is a problem, again, what would you do? Do you have enough drugs, or would you shift?
Great question. I think this comes to the heart of, you know, all AFib is not the same. So certainly this is where, you know, if the patient's symptomatic burden of atrial fibrillation is high, if symptoms due to the AFib like dyspnea or fatigue, or they have, you know, other cardiac issues that are influenced by the AFib like heart failure, I really try to work with their cardiology doctor to try to optimize that management. And then we may consider either for a patient who's been on therapy for a long time and their disease is controlled, that may be a patient where you can just stop the therapy and watch them off therapy. Or if they're earlier on in treatment course and you think they need therapy, you may be able to switch that patient to an alternative agent. But for patients perhaps that have, you know, asymptomatic AFib, it's not a high disease burden, that sometimes I will still try to manage with, you know, other agents if needed, or monitor that patient.
Okay. And one question Dr. Suresh asks as to how do you consider acalabrutinib to be superior to ibrutinib? In a sense, probably he's asking about the PFS and OS rates and all that on a head-to-head basis.
Yeah, I think, you know, from an efficacy perspective, and, you know, we'll reference the Elevate Relapse Refractory study, I don't think there are differences in the efficacy. What I think is important is differences in toxicity. And so the superiority to me, or why I choose to use acalabrutinib in almost all of my patients with CLL is because of the toxicity profile.
Thank you, Dr. Krish Patel, for that excellent talk. And you are on the panel, the next panel that's coming up. And so I think you will be answering a lot more questions there. And I now request Dr. Pawan Kumar consultant medical oncologist from the Basavatarakam Indo-American Cancer Hospital and Research Center, who would conduct the panel discussion. And his panel members are Dr. Krish Patel himself, Dr. Satish CT from Bengaluru, Dr. Mallikarjun Kalashetty from Bengaluru, Rakesh Reddy from Visakhapatnam, Dr. Narendra Kumar from Hyderabad, Dr. Stalin Bala from Hyderabad. Over to you, Dr.
Thank you, sir. Thanks a lot. I hope everyone is audible.
Yeah, you are audible, yes.
I'm audible, right? Yeah. So good evening, everyone. Actually, it's a great privilege to moderate a session with so many enlightened minds. So probably this will be more helpful discussion for us from Dr. Krish Patel and everything else. So I will share my screen. Directly start with the presentation. Yeah. So this session will be about a case-based panel discussion with all the panelists in. The 3 cases, one will be elderly and young patient and a relapsed case. And what's our experience with dealing with the same kind of patients. First case is a 74-year-old patient presenting with cervical lymphadenopathy with comorbidities like hypertension, high cholesterol, and BPH. Extensive notes and leukocytes are 88,000, hemoglobin of 11.1, and the platelets of 104,000. Flow confirmed of CLL, and marrow shows 70% of the marrow is replaced by CLL, and imaging shows 12 centimeter node in the mesentery and 8 centimeter troperitoneum. And FISH shows a DEL 11q, and it is IGH unmuted. IGH unmuted. The question, how will you manage this patient? Are there any additional tests to be done? First, I want to place this question to Dr. Krish for his opinion.
Sure. And do you mind, can we go back to that profile just to see that again? Yeah, so a couple things that I think about. So probably the most important, if we have all agents available to us, are the cytogenetic and molecular testing. So this patient has an 11q abnormality and is IGHV unmutated, which would suggest this patient has a poorer prognosis with chemoimmunotherapy. In thinking about indications for therapy, it sounds like the patient's lymph nodes are quite bulky. And so this would be a patient where I would be more concerned about a venetoclax-based regimen because of the risk of tumor lysis. This patient would likely need to be hospitalized if they were going to receive that regimen. So this, I think, is a patient that I would usually treat with a BTK inhibitor based on the high-risk features and bulky disease. And in this setting, often I would treat this patient with acalabrutinib because of, I think, the more distinct toxicity profile.
Thank you, Dr. Krish. I want to pose the same question to Satish. You want to have anything to add on? Satish, sir?
I think Dr. Krish has
elaborated, yeah.
Yeah, like this one, yeah, definitely that BTK inhibitor is a choice actually, and like because already this patient is showing a high risk factor, is it like FISH is showing division 11q and even you are audible?
Yeah, now you are audible.
The high risk factor is there. This case, I'll try to keep a BTK inhibitor as one of the choice right now actually. And definitely they don't do well with the like overall It is like immunotherapy, like they don't do a long term. Actually, I try to keep a beautiful inhibitor. See, currently, like there are two molecules are there. Any one of them can be chosen. Actually, like we have heard about like a fish. Like both the things, like we have heard about the toxicity of this, like case of person the shade actually. Even we have faced a lot of problem with the both the interruption and toxicity and
Sorry to
definitely.
interrupt, sir. There's some audibility issue from your side. Satish, sir?
Yeah.
I think slightly you're losing your
Yes, sir.
audio. Yeah.
Sir, my side is a high risk case. Like I'll try to have a BTK inhibitor is a choice, either any one of them. Cost is an issue in our Indian practice, like like because I try to BTK inhibitor any one of them, but Acalabrutinib because of the toxicity, like it will be more safer compared to the Ibrutinib. It is my choice.
Thank you, sir. Mallikarjun, sir, you want to add on something? You're happy with?
No, I think they have answered most of it. See, elderly gentlemen with high risk CLL. Only thing is, well, Dr. Krish mentioned at the baseline, if you have a choice, perhaps doing a NGS to see for TP53 mutation, because sometimes fish for CLL can miss a 17p deletion, and in about 20 to 25% of patients who have fish 17p negativity, I mean, who are not there to have 17p deletion, may have a TP53 on NGS. So that is something for us to consider if you have a choice.
So that's what it's more like prognostification right now,
Yeah,
not predictive, because being any
therapeutically correct.
Triple hit,
correct.
probably. Yeah. Probably I'll move on next. Probably I'll add on other questions to other panelists.
Can I ask one question, Pravan?
Yeah, please, sir, go ahead.
I mean, because every panelist there, in the same case, suppose this patient won't have the bulky lymphadenopathy with the high risk features. Would you like to observe a 74-year-old patient, or do you want to treat him straight away even without a bulky lymphadenopathy?
Dr. Krish, you want to answer this?
Sure. Yeah, I think that's a fair question. I mean, if the patient didn't have bulky nodes, maybe the cytopenias are not so concerning. The patient does have some borderline thrombocytopenia that could be observed and watched for some time. But also, I think time to treatment will likely be short because of those high-risk features. But I think if they didn't have bulky nodes, one could certainly observe this patient closely if that was the preference.
So does it change if the patient have the deletion P or TP53 mutation, or do you manage the same way those patients also?
I think, overall, in terms of observation or not, it wouldn't, but we might expect that time until the patient has progressive change or meets the IWCLL criteria to be shorter if they had a P53 aberration.
Thank you, sir.
Yeah, then we'll move on. Same thing, the whole scenario, like IGHV, unmutated and mutated tend to do better than unmutated. I don't want to go much of these details. Dr. Fish has already spoken through. And fish definitely makes sense. And one thing Dr. Mallikarjun had added, like probably we need an NGS to confirm, even if the fish negative 17p deletion, the P53 on NGS really matters. It's more like a prognostification because in high risk, anyway, one high risk features, we are going for a BTK inhibitor. And subsequent and the initial trials of adding obinutuzumab, rituximab, I don't want to go on much of the details here, probably risking, and venetoclax, obinutuzumab. So definitely we are outweighing the chlorambucil all arms. I don't want to go, and ibrutinib, which makes sense. And I think we have already gone through the discussion on ibrutinib and acalabrutinib difference and talk between by Chris. Probably I will not go into much of these details. Now, coming to another scenario where we have a young symptomatic patient. So, he's a 45-year-old patient, no comorbidities. He has a B symptoms, fatigue, and cervical lymphadenopathy for 5 months. And he developed lymphocytosis at 40 years. He has been on follow-up for almost 8 years. Now he has a hemoglobin of 8 grams, TLC of 1,60,000, and platelets are 90,000. And when he had a regular CLL panel done, he had IGHV mutated and the del32 deletion. And there's no P53 mutation. So how we'll manage this patient, and would we prefer therapy which has a chemotherapy or wait and watch? So I'll start this question with Dr. Rakesh.
Yeah, Pavan.
Yeah,
So, yeah, young patient looks like a fit patient with symptomatic CLL, standard risk CLL. So my choice would be to give chemoimmunotherapy for this particular patient. So I would see maybe if I can do FCR for him. This is one scenario where I would actively consider chemoimmunotherapy for this young patient.
Definitely, even many will agree with you. Dr. Narendra sir, you want to add something?
Can you go back to the slide? Okay. Right. He progressed over several years. So first, I would like to see whether, of course, based on the CBP report, definitely he's a candidate to treat. But I would like to see whether he had a hemolysis for the anemia. I would like to check for the Coombs and rule out any autoimmune. Probably I'll correct his anemia. Sorry.
Coombs negative, non-hemolytic.
Yeah, I mean, I'll try to correct his anemia. I'll try to observe for a few days, and I would like to see, because he has progressed over several years. I'd like to see for a few more days before I start to treat this disease. If he progress within 1 or 2 months, in next few months, then I'd like to go with the chemoimmunotherapy, like FCR, what Rakesh said.
But he has B symptoms, and he's a rise stage 4.
That is fatigability could be because of anemia, right? So
yeah, platelets are 90,000.
Yeah, I know. I've seen that 90,000. It's not like I would like to treat when it's dropped down to 70.
Sure, sir. Next, Stalin, sir, you want to add on something? Stalin?
Nothing, sir. For this symptomatic young patient, so I would like to go with chemoimmunotherapy because it is a fixed duration and retains a good MRD levels, and for a fixed duration of time, six cycles. So I will go with FCR chemoimmunotherapy in these patients.
Perfect. Now I'll come back to Dr. Krish. Probably you are an expert, so you want to add anything on this, sir? Sir?
No, I think it was highlighted well. This is the type of patient where we still may think about FCR-based therapy. Up to maybe 25 to 30% of IGHV mutated patients without P53 aberrations may never relapse. So if the patient's fit and they're young and that's within their goals, then that may be reasonable. So this is the rare circumstance in which I think, that would be maybe a chemoimmunotherapy patient. And if chemoimmunotherapy, certainly FCR.
That's great. So if there is this question goes to Dr. Satish, sir. If there is the same patient, he says, I somehow don't want to take chemotherapy for a number of reasons. There's any intent of starting a BTK inhibitor upfront? Satish, sir?
Yeah. See, this patient is
it's an approved indication though.
Yeah. This patient is a symptomatic. I like to wait and watch in this patient. As per with the panelists like they said, chemoimmunotherapy is a choice. Is not keen to go for a IB chemotherapy. The alternate option is even still BTK inhibitor can be. That is one of the choice you can go. But like elderly patient not fit for FCR, I may go for arbendamustine. That's what this is one thing. Like this is a young patient, definitely there is nothing. Like whatever your question is alternative, yeah, it is a BTK inhibitor can go alternative.
So, probably I'll take the next question. As everybody has gone through, so in Indian scenario, most of us, because most of our patients being a standard risk, most of our patients prefer somewhere we to stop the treatment, fix the treatment. So FCR has shown great area. Patients who are low risk tend to do really better compared to FC and old data. So FCR still stands it has its own importance. But coming to FCR, BR, young patients, again, FCR is definitely going to do better than BR, whole thing. But there is no direct comparison. But in the era of BTK inhibitors, even in young patients, starting BTK inhibitor makes sense. The problem with the BTK inhibitor being it has to be continued for probably till the disease progression. There is no stoppage anywhere. And there is an issue now coming up in CLL with the MRD, which any BTK inhibitor cannot take it, and probably addition of venetoclax or obinutuzumab will make sense. So this, obinutuzumab will make sense. Now coming to the third case, is again a relapse setting with a high-risk features. He's a 67-year-old man presented with weight loss, fever, typical B symptoms, and he was previously treated with for CLL with chemoimmunotherapy with R-benda 6 cycles. He was symptoms-free, diabetes and OHA, and he was IG, and subsequently biomarker testing showed IGHV unmutated and del-P. He was del-P positive. Now he has a hemoglobin of 11, platelets of 1.4, TLC of 45,000. Physical examination, spleen is palpable and cervical. Technically, relapsed with these symptoms with high-risk mutations. What is the most appropriate management of this patient? And so probably, what will be the choice of treatment? Anyway, we probably want to use BTK inhibitors or BCL2 inhibitors. So let's start with Dr. Mallikarjun, sir. So what will be your take on this?
So he's an elderly gentleman with relapsed CLL. In terms of cytopenia, he still is doing fairly okay, but like you pointed out, he's got constitutional symptoms. And I guess in view of him having deletion 17p and IGHV unmutated BTK inhibitors are the choices. And then if you have the access, certainly I would like to start with Acalabrutinib monotherapy, number one. So I individually, and I'm sure most of us don't have experience of combination of venetoclax with obinutuzumab, so I don't think I would even think about it. So BTK inhibitors are the way to go for this patient, really.
Sure. I totally agree with you, sir. Dr. Rakesh, you want to add something on this?
Yeah, with regard to venetoclax availability, we already have this issue, but that is probably one option, one limited time option that is still there, very attractive. But as Sir has pointed out, Dr. Mallikarjun has pointed out, I don't have any experience. So something that I've used is in this scenario is ibrutinib. Difficult to manage, but still was able to do. Acalabrutinib I have not, but so probably the options remain BTK, both the options that you have mentioned. So realistic options are BTK inhibitors. Venetoclax is something that I would love to try in this particular scenario.
Great. I totally agree with most of our in Indian scenario BCL2 inhibitors. Venetoclax is still not approved, and we are trying to import and probably smuggle from Bangladesh. But yeah, we have our own issues. Narendra sir, you want to add something on this?
Yeah, can we go back again? I would like to see.
Yeah.
So if you see the history, weight loss, fever, night sweats, definitely it fits into disease progression of CLL, but still I would like to rule out the infection because I'm going to use a BTK inhibitors, which again can increase the risk of infection.
Totally.
If you see the CVP, his counts are okay for me because if I would rule out the infection, I'm comfortable going ahead with the BTK inhibitor.
BTK inhibitor.
Yeah.
But Stalin sir, do you want to add anything?
Yes, sir. Same BTK inhibitors. Anyhow, we have not still the luxury of using a BCL2 inhibitor. So definitely a BTK inhibitor is my choice.
Experience only evidence.
So Dr. Krish sir, probably you can add on because biggest problem with us is non-availability of venetoclax. So what's in your clinical practice, how you want to take it?
Yeah, so a little bit different in the US. We do have an approval for venetoclax in combination with rituximab based on the Murano trial. That's a 2-year regimen, so different than Obin in the frontline setting. So I discuss option of BTK monotherapy or the venetoclax rituximab regimen. I think because it's 2 years of ven-based therapy in the relapse setting, people tend not to be so, it's not the same as being on 1 year. And most of the time my patients and I will decide we're going to use a BTK inhibitor in this situation. So I agree with all the discussion that's been had.
I have a small question for you. So taking the MRD in picture in upfront, probably in upfront setting also, is it if ibrutinib is acalabrutinib for some reasons we don't, it's not cost effective though. Some reason we have obinutuzumab and I have an ibrutinib, but there's no clinical trial though. Is there a point using obinutuzumab and ibrutinib upfront, at least for the MRD benefit?
Yeah, so there are some phase 3 studies looking at the combination of ibrutinib and obinutuzumab, just like there are with acalabrutinib and obinutuzumab. And what you will see is that you get a slightly increased CR rate, slightly increased MRD rate. I think for me, because the BTK inhibitor is given continuously, is given until disease progression, that it's hard for me to know what that added benefit is. If we're using time-limited therapies, then I think MRD has a very important prognostic significance, which is to say that at the end of therapy, patients who are MRD negative are likely to have a better progression-free survival off therapy. I don't know that the same is true when we're using continuous BTK therapy, because we know that that response can evolve over years sometimes. And so I tend not to be so concerned about MRD in a patient that we're treating with continuous therapy.
Probably will put the things for panelists. If you have any questions to go forward, Dr. Krish or anyone.
Yeah, so if I may, Dr. Krish, couple of things. One, are there any absolute contraindications for use of acalabrutinib in clinical setting? Is there something, if it is there, we must say, no, we can't use it? That is number one. And number two, your experience of using these BTK inhibitors in relapsed refractory Waldenstrom and mantle cell, how would you use them? I'm sorry, I'm digressing from the topic. Yeah.
No problem. So the first question, are there any absolute contraindications? I would say largely no absolutes. Relative contraindications, I think about, acalabrutinib can't be given with a proton pump inhibitor. So patients who have a strong indication for a proton pump inhibitor, so maybe somebody who has bad peptic ulcer disease, a H2 blocker is not an appropriate alternative. That would really be the one circumstance where I might choose a different agent. And then in terms of relapse refractory mantle cell, that is an approved indication in the US. I'm not sure if it is in India, but there we actually have 3 BTK inhibitors approved in the US, ibrutinib, zanubrutinib, and acalabrutinib. And for the same reasons we discussed earlier in terms of side effect profile, I tend to prefer acalabrutinib for patients with relapse refractory mantle cell lymphoma. There's certainly emerging evidence of acalabrutinib in a number of B-cell malignancies, and I think the safety profile will be similar across those, but trials in Waldenstrom's are still ongoing, and so in the US we have approval for mantle cell lymphoma and CLL.
Thank you so much. Thank you.
It sounds like you have approval for mantle cell lymphoma in India as well for acalabrutinib.
Yeah.
Dr. Krish, one of our panelists was asking the pathophysiology of the cause of atrial fibrillation and hypertension.
Yeah, so this is still a bit unknown. Nothing I say is an absolute certainty. There are a number of different kinases that may be important in the BTK family. So I mentioned earlier, TEC kinase is a BTK family kinase. Is found on cardiac tissue as well as platelets. So there may be some importance there. But ultimately, this is still being, I think, worked out and trying, and we need a better understanding of exactly what drives that, but it may be other kinases in the BTK family.
Great. Anyone else has any questions? I think. Thank you, everyone, from the panelists. It was a great discussion.
Thank you, Pawan.
Yeah.
Thank you, Prasad. Thank you, SVSS Prasad.
Thank you.
Dr.
Thank you, Dr. Pawan. That was a good panel discussion. It has brought out some important points. It's my duty now to summarize today's proceedings. The important thing is, yes, acalabrutinib, less toxicity, good efficacy. We have to be actively considering in all high-risk CLLs. That's the important message for today. While we also have revised our subject regarding the CLL management, all of us should consider doing NGS, which is now very much available for all our patients, so that we pick up all the mutations and abnormalities. And for the low risk and fit and younger patients, FCR regimen or a chemoimmunotherapy regimen is still in order. It would probably give them a long disease-free interval or something like a cure. And for the high-risk patients with all these, especially the deletion 17p or TP53 mutation, or with disease-related complications, we have to be considering the BTK inhibitors. And if we are to consider the BTK inhibitors, efficacy-wise, both ibrutinib and acalabrutinib stand same, but toxicity-wise, acalabrutinib scores much higher. So also in the relapsed refractory CLL setting, we have acalabrutinib either alone or in combination with obinutuzumab scoring well. And one of the important issues that has come up is MRD. While the experts are still not looking at MRD, probably that's something to be looked at especially in younger patients where transplant in a refractory setting is considered. And in that respect, venetoclax plus obinutuzumab would probably be helpful. With these few learning points, I would conclude the session and I hand over the proceedings to the organizers.
Thank you very much, Prasad sir. We've come to the end of this session, and it was a very engaging evening that we've had. We've had a lot of discussions between the experts and our Indian experts as well. So I hope everyone had a very good learning experience from this webinar. And I would like to thank Dr. Prasad for chairing this session, Dr. Pawan for moderating the case-based discussion, and all the panel members for joining us and giving us their valuable inputs today. And also I would like to thank Dr. Krish Patel for his valuable time to joining us in the early hours of his morning and sharing his experiences with the molecule with all of our Indian experts. Thank you very much, sir. And I also thank Mice Ideas for organizing this for us. Thank you very much and have a very good evening. Stay safe and have a good evening. Thank you very much.